the August 25th free Phasis webinar on PQRS reporting and meaningful use attestation. It's an update for the 2016 year. We appreciate everybody attending. Alrighty. So I'll go ahead and get started. Here's our agenda for the day. We are planning on doing an overview of just PQRS. We're going to go over the reporting options. We're going to explain what it is that you should be doing right now, if you're not already doing it, to be prepared to successfully report for PQRS. We're going to go through the different ways to report if you choose to participate, and also kind of talk about what will happen if you don't participate. We're also going to talk about additional things that you need to do by the end of the year, but they're not imperative that you get them going right now. Those are all relative to PQRS. We're also going to jump in and talk about meaningful use. So before I get going, anybody have any questions or anything you want to make us aware of? I'll go ahead and unmute Connie now and see if she has any questions. Connie, are you there?
Yes.
Yes.
Hi there. Okay, I ended up muting your microphone, so you might want to self-mute, which is just that little green icon that looks like a phone. You click on that, it'll mute you, and if you unclick on it, it'll unmute you. There was just a lot of background noise in your office. Perfect. That's awesome. Okay. So,
Brad, hi.
Great. So let's go ahead and roll. So the differences for PQRS for this year. Let me make sure we've got the right. There we go. The differences for PQRS in 2016 compared to the previous years is that it's been expanded now to include nurse practitioners, PAs, and therapists, as long as they're billing Medicare Part B. Previously, you didn't get any bonus credit for reporting for those extenders, as they're called. Now it's been changed so that you will get penalized if your extenders aren't reporting for PQRS. So one of the things you can do is just run a report by billing provider. For Medicare, we can help you with this. If you've got your extenders that are billing Medicare, then you're going to want to make sure you include PQRS reporting for them as well. And it's possible that your extenders will have fewer than the required number of cases, which would help you to exempt out of it. Another change for PQRS for 2016 is that they have added 3 new measure groups, and I am very keen on measure groups. They are the easiest way to report for PQRS without having it be an onerous amount of time that you have to spend on it. So we'll go into what a group measure is in a little bit, but just know that there are 3 new ones: multi-chronic conditions. That's supposed to allow primary care offices to be able to chime a little bit, or specialists that are getting patients that they're managing for chronic conditions. There's also the cardiovascular prevention group, and it's part of the Million Hearts CMS initiative. And then there's also a new group measure for diabetic retinopathy. So these group measures are ways to report your PQRS data without having to do a line by line every patient and every measure that you've selected. Another thing to keep in mind, and this is not new, but there is a penalty for not reporting. Just like last year, the penalty for not reporting successfully for PQRS was going to be a 2% payment adjustment in 2017, next year. Not reporting this year in 2016 would create a penalty or a payment adjustment in 2018. So, you know, what you do today is going to affect the money you get down the road. Now, this last change, normally you might think it would be time to stand up on your chair and cheer, because this is the last year for separate PQRS reporting. Unfortunately, that doesn't mean it's going away. It's just changing the way that we're going to be reporting. We will no longer need to log into registries to select specific groups and things like that. They're going to start integrating reporting that you do with the requirements that they're going to have for you under MACRA. And that's a whole initiative to try to get data, more data so that Medicare can measure. Alrighty. The options for 2016. There really is no change in the options. There's the same 4 options that existed last year. First one is claims-based, and then if any of you are submitting PQRS codes today, that's great. As long as we run reports and make sure you're going to be over the threshold, you can just live with the claims-based. However, I'm always in favor of the registry-based because it gives you the chance to kind of review the data before it is submitted. With claims-based, it's one and done, and that's your only shot. Now, if you're doing a claims-based reporting, that means you're doing individual measures, and the requirement for individual measures for 2016 is going to be 9 measures, same as last year, across 3 domains with 1 cross-cutting measure, and we'll talk about what a cross-cutting measure is later. So you want to make sure that you're picking the right measures to report on. If you don't, you can do all that work, and if it's not a 100% score and you're not 100% successful on all of the measures you're reporting on, then you will fail PQRS and be subject to the payment reduction. So we don't want that to happen to anybody. Registry-based is the other option. That's my favorite. What the registry allows you to do is submit in batches at the end of the year, and it gives you the opportunity to review things. It also creates an opportunity for you to use a streamlined reporting option, which is called measure groups. And when you are reporting on a measure group, what you're basically doing is selecting all of the individual measures that roll up under a measure group. You have to have at least 1 affirmative or numerator to report on in each of the measures. And then once you hit those 2 thresholds, you're able to report on only 20 patients. You can do more if you want. And you just have to have a majority, or 11 of those have to be Medicare Part B. So that would mean you could cherry pick. You could get your 20 patients that have data, but not an onerous amount of data where you're going to spend half an hour keying in the survey results when you're filling out the registry for a measure group. So cherry picking is a good thing. The other 2 options, still unchanged from last year, is EHR reporting. And by the way, this is where everything is headed. When we get to next year, claims-based, gone, because there's no more regular PQRS reporting. Registry, gone. EHR reporting will be the norm. And then the large group reporting option, that is something that won't apply to anybody on this call. It's for large groups of 25 or more, and then there's even a separate level for groups of 100 providers or more. So there's a ton of literature and guidance in all of the PQRS help files that CMS have that relate to GPRO. You just want to ignore those entirely. There's nothing in there that will apply to you. Alrighty, so you might be asking, well, that's great, but how do we prepare for PQRS? What do we need to do to be able to report? And so again, if you're going to be using the measure group, you need to select a measure group that applies to you. If you're going to be doing individual measures, you need to pick those 9 individual measures. Remember, it has to be from 3 domains, and it has to have at least 1 cross-cutting measure. We're going to give you a list of cross-cutting measures that you'll have, so you'll know which ones to include. So you want to pick that. And then the most important part of this is once you've picked the measures, you want to review the data to be reported within each measure. So if you look at the picture on the right of the screen here, you're going to see the measure. number 178. It happens to be for rheumatoid arthritis, and the domain that it lives in is the effective clinical care domain. And essentially, any of your patients that are aged 18 years or older, right here in the description, with a diagnosis of rheumatoid arthritis, and so that could be a whole lot of subdiagnoses that live in that you have seen in the last 12 months, that's going to create the denominator. So, there's not a lot of work you have to do to know who's in the denominator other than run a report. The trick is going to be making sure that when it comes to the numerator, you have at least one for each measure that you select, whether it's measure groups that you're reporting on, and maybe that measure group will have 5 to 10 individual measures, or if it's the individual measures where you're picking the 9 from 3 domains with 1 cross-cutting. Regardless, you got to make sure you have, for every measure selected, one affirmative or a patient that lives in the numerator. And if you see down here, the definition for a functional assessment, you'll need to have performed that actual clinical task, and then you're going to need to be able to have it documented so that if you were doing claim-based reporting, you would have reported a 1170F code. If you're going to be doing the registry reporting, then it's going to be more of an answer that you'll just click, but the question would ask you if you've done that assessment. So hopefully that gives you a little insight. You're going to want to pick measures, read the measure, make sure you've got patients that would roll up into the denominator, and make sure that you have at least one patient that you'll be able to answer affirmatively so that you get a numerator patient for that. Then, and this is probably the most critical, you're going to need to incorporate this data collection into your progress notes. You're going to need to make sure that you've got it documented somewhere that you did perform this functional assessment. That way, when you're filling out the answers in the registry, whether it be for a measure group or an individual, you'll actually be able to verify and validate that you did indeed perform the required actions. So, any questions about looking at the measures and how to read them? Okay, we can definitely revisit that later if need be. So, how do I pick this measure group? You're going to want to consider your practice and what type of care you deliver. So, consider the type of patient you treat. Are you a specialist? If you're dealing exclusively with conditions in the feet and ankles, then you want to make sure that the questions, the measures address that, or at least address something that's of general medical interest, like the cross-cutting measures that would still apply to you. And then you want to consider the type of care. Are you more of a preventive office, or are you dealing with managing chronic conditions, or perhaps you're a specialist dealing with acute conditions? Again, you want to see how those translate to the different measures or measure groups that you're going to look at. And then the last thing to consider is the setting in which you deliver care. Some of the individual measures speak specifically about surgery, something that wouldn't be appropriate if you're exclusively delivering care in the office. Conversely, if you're only seeing patients in an operating setting, then some of the questions that relate to preventive care and office work is just simply not going to apply to what you do. So you want to look at the measure group. You want to look at every single measure within that group so that you can determine, and then you want to further look at the actual detail of that measure to make sure that you have patients in the denominator as well as being able to answer at least one time to the affirmative so that you have one patient in the numerator, allowing you to successfully report. And, oh, by the way, that needs to be a Medicare Part B patient. Whoops, sorry about that. That needs to be a Medicare Part B patient that has the affirmative. All right, so what you're seeing right here on the screen is actually from the actual list of measures. This happens to be the listing for the diabetes measures group. In that measures group, there are a total of 6 individual measures. Measure 1 for diabetes, hemoglobin A1C, the preventive care and screening, that's measure 110, an eye exam. So if you're going to select this measure group and you did not perform eye exams at least on one Medicare Part B patient, this one's not going to fly for you. That's why looking now today to see what needs to be documented is going to allow you to do this. So let's say you don't normally do eye exams, but you know how to do them, and you make an exception and you do it on the one Medicare Part B patient that would be in the denominator. Now you're gold. You'll be able to report on that particular measure. There's also the medical attention for neuropathy, the diabetic foot and ankle evaluation, as well as the tobacco use and screening. Notice that tobacco one, that's a cross-cutting measure. That would live across all different types of domains. And this domain is the diabetes measure group domain. So really, really critical that you don't wait to the last minute to decide which measure group I'm going to try to use, because at that point, you're going to be stuck with, did I document enough to be able to report on that measure? As opposed to, if you're looking at today, you can make sure that, yes, I will make sure I document at least enough times to get a couple of patients in the numerator. You may even decide, you know what, it's a good idea clinically for us. I'm going to go ahead and start doing that on all my patients that fit this particular type of criteria. So, you know, that would be up to you, but making sure you're going to collect the data, that's critical to your successful reporting. Now, there's more than just that. What you have to do today will set you up to successfully report, but you also need to do just a couple of other things. One of them is going to be to run reports to make sure that you actually do have patients that are going to live in that denominator. It would really stink if you got to the end of the year and you're all ready to go and you ran one of your reports and lo and behold, you don't have anybody in that denominator. If you're making sure you got them in the numerator, that's not likely to happen, but just kind of, if you get the idea, you want to monitor this as you're moving towards it. So this particular image is just a snippet from the reports page. If you go to reports and then on the actual reports that are available, there's a section in the middle on the bottom that's medical reports. You're going to see that it has basically PQRS reports right here. That's what this is a picture of. Now, when you go into the PQRS reports, you're not going to see any reports for 2016 or 2015 or even the year for that. But you will see a listing for 2014, although there are no reports there. And then you're going to see 20 years, 2013, 12, 11, 10, backwards like that. As long as the measure that you're looking to run is identified in the most recent year, it's a report that will work for you to generate, to see if you have patients in that population. Now, these reports are designed around claims-based reporting, so you're going to end up with a whole bunch of missed cases if you did not, in fact, submit the required codes for claim-based reporting. Don't worry about that. Really, all you need to do is make sure you have patients in the denominator or a population group, and then to go through and make sure that you've got some patients that will work. Again, if you're doing the individual measures, you're going to have to report on at least 50% of your patients, which could be a pretty huge number. If you've picked a measured group, you're going to be able to get by with only 20 patients per provider. So again, I highly recommend that. If the PQRS report does not exist, then you're also able to run the CQM reports, the quality measure reports. You can look at meaningful use, quality measure reports as well. You just want an overlapping report that reports on the same thing to give you a patient population. Now, if none of those are options for you, you picked a measure that is brand new or not reflected in the PQRS reports or CQM reports, then you can easily put together something based on Clinical Query Builder. So if we go back up to this example here. If you had to build a clinical query, you could simply say, I want to know all my patients that I have seen in the last 12 months that have a diagnosis of RA, that are 18 years of age and older. Those are all elements that you can include in your criteria for reporting on the clinical query builder. So you've got several different options to allow you to get reports, to make sure you get patients in the denominator. Of course, all those patients that are in the denominator, you want to look through and make sure that you're documenting enough to be able to answer questions for each of the measures in at least one Medicare Part B patient. That's kind of this part right here. Review the progress notes. Make sure you don't have any data gaps. Like I said, if you get to the end of the year and you haven't collected data, you're going to be in bad shape. All righty, so how do I report? I mean, what's involved with a registry? Well,
maybe before you get into that, Matt, we've got a question from...
Oh, absolutely. Thank you very much.
Yeah, you bet. Take a look at the chat.
All righty, so we have in the chat from Becca. Thank you, Becca. I have a provider that is going to do the diabetes measure group. Measure 1, A1C for control. It says that you have to report patients greater than 9 A1C. She would only need one patient of the 20 to have an A1C greater than 9. Correct? Yes, as long as that patient is a Medicare Part B patient, yes, you're going to be good to go. So that would be the only thing. Make sure it's the right payer. Thanks for asking that question, Becca, and let us know if that's not an adequate answer. All righty. So how do we report? Well, you got to start by selecting a registry. And don't forget to sign up by their deadline. I know that we've had a few people that wanted to use a particular registry, and they had a cutoff for whatever reason of November 30th, and on December 1st, they were trying to get the registry to sign them up, and they're like, no, we're closed. We're going to barely be able to handle the work we have. Sorry. And they had to move on to a different registry. That could be more costly, maybe harder to use. When you're selecting a registry, you want to look for a couple of things. Most importantly is whether they're going to be able to report what you want. So if you're doing individual measures and they don't support the individual measures, only measure groups, it's not going to be a good pick. This one down here, it tells you the individual measures. You just want to make sure the measures you're going to report on are supported by that registry. And of course, if they're going to do the measure group, then you're good to go. Notice how some of them only support certain measure groups. Now, if you want to pick a registry that is aligned with your specialty trade organization, like the the AUA or the AMA or any of those, American College of Surgeons, anything like that, you might be surprised to find that you're actually going to be able to have that as part of the dues you pay to be in that trade organization. So start there if you can't decide. If you've used one in the past and it's been successful, make sure they haven't changed and they're no longer supporting the measures you need. Once you've got one, get signed up in time and you should be able to go. Now, those registries are going to have their own methodology, their own training. That's not something that we're going to support for you. So once you sign up with registry, make sure that they're helpful, you can communicate with them, and that you're going to be able to work. But picking the right registry can make things super easy. Now, if you're doing measured groups, you're probably not going to really care too much because data enter 20 patients, their information and all the data, I mean, we're looking at a couple hours tops. However, if you're going to be reporting on individual measures and you now have to hit 50% of claims, and now you're talking about thousands of patients instead of just 20 patients, at that point, you might want to make sure the registry supports uploading demographics, uploading reports. That's where using those reports, so PQRS, CQM, or Clinical Query Builder can automate what you're doing. In the past, I worked with people that used the reports to create the spreadsheet. They were able to then populate the spreadsheet with the answers that were then uploaded into the registry, and they were able to report on thousands of patients with maybe 4 or 5 hours worth of their work involved. Remember, all of this is so that you can avoid the 2% payment reduction on Medicare, and more importantly, be aligned with the requirements that you're going to have in the future for using the electronic medical record, lest you get deductions from all the payers. You know, the commercial payers are right behind. All righty. So we talked about cross-cutting measures, and the question is probably going to arise, what in the heck is a cross-cutting measure? Well, it's basically just a measure that is broadly applicable across the different specialties or different groups of providers. We saw the smoking. That was one that went across all domains. This one here, the alcohol use and screening, that cuts across all the domains. So we do have files that we're going to send you. We have anything you've seen an example of, the listing of the measures in the measure groups with the description of what's in the denominator and numerator, the cross-cutting measures that you see here, the list of registries that we saw on the previous screen. We've got all those. Everybody on this call, we will send those to you via email along with this PowerPoint presentation. They're also going to be available on our website, and we are recording this session. All righty, any questions before I turn it over to Bradley for meaningful use? All right, so Bradley, if you would like to walk us through the meaningful use update for 2016, and I'll chime in if there's anything additional, for sure.
Okay, fairly self-explanatory, but the proposed rule, the CMS is proposing that they reduce the current reporting period from 365 to 90 days. So that's nice. We'll monitor that and see when that gets announced. I mean, that probably ought to plan on it not happening just as a safeguard. You know, remember last year they announced they made those changes. They announced those changes, and literally we were, you know, over 10 days into the final reporting period. So meaningful use is not going away, as Matt was saying before. It's getting rolled into MACRA and MIPS, and that's the new program, and it's going to be more performance-based as opposed to measures-based, where you're going to be getting a score as opposed to you have to pass each measure, and so have to stay focused on that. First-time attestation has a different set of requirements and time frame. So if this is the first time you're going to get involved, it's less onerous than those who are stage 2 or have been doing it for a long time. But that's all laid out. You can get all those rules, and happy to send you any PDFs you might require from the CMS website. This last number 5, I've gone through a lot of audits now. I'm submitting documents for audits all the time. As a matter of fact, it became apparent this year that everybody we submitted meaningful use metrics for were getting audited. And as a matter of fact, I'm going through one right now. But I've learned through this process not to fear the audit, but just to keep supplying the documentation that's necessary. And the auditors are actually, at this juncture, in my experience, pretty customer friendly, extremely customer friendly. You can call them, they'll talk to you. I've asked for extensions. They've done that. So bear that in mind. As the PowerPoint says here, don't fear the audit. It's just a matter of supplying the documentation.
Right. And Bradley, one thing we did this year was to preemptively file waivers for all of the clients we have using EMR. We did this as a defensive measure, and so basically you have the luxury of not even bothering this year with attesting. I don't recommend taking that approach, although it's nice to know that if there is an issue, you can kind of go, okay. The reason I don't recommend not doing that is keeping in mind that next year you're still going to have to report all the same information. You're still going to have to meet all the same measures. It's just that you don't have to do it via the attestation model. You don't want to just blow it off to the point where you end up with a 0 score next year. That means like the penalty's coming if you don't submit. So, thanks, Bradley. Back to you. Let me go to the next slide. So go ahead, Bradley.
Oh, so as I was saying before, this meaningful use is just morphing into this new program called MACRA, which of course is an acronym which I won't even attempt to translate here. But the proposal applies only to clinicians who bill Medicare Part B. CMS is going to keep their 2-year look-back policy. And then that third point, providers traditionally excluded from meaningful use won't be scored on EHR use. So keep all this in mind, and we'll make sure that everybody's up to date as much as we possibly can.
And we apologize for all the verbiage on this slide. I hate slides like this. My apologies. But there's going to be a lot of change, and this slide in particular, when you get your packet, I think you all want to print out this slide and make sure you stay focused on what it is that you're going to be measured on in the coming years, because there are while it's not going to be the standalone program, you're still going to have to report as part of MACRA. Now, it could have an impact of up to 4% downward, and yeah, there is an upward possibility of 12%, but don't get too excited about that. The Cleveland clinics of the world are going to gobble up the upside. Your goal as a solo or a small office should be to meet everything you can meet so that you have no deductions. If you get a little bonus along the way, great. But the new rule, as we mentioned, abandons that all or nothing approach. You're now going to be scored in MACRA, and I'm talking about 2017's performance year. You're going to end up being scored in 2 different parts. One is participation, and that is what basically you've had before. Is your EMR certified? Do you have a risk analysis? All of that. And there's also going to be the performance aspect, which is now going to be a little bit new. There was some performance evaluators put in on previous attestation that was like where we had thresholds and things like that. But now we're going to get where performance is going to be measured, and instead of it being a yes or no, it's going to be where do you lie on the continuum, and that will directly affect your reimbursement. So the participation component, that's half of your base score. It's made up of the risk analysis, the immunization registry, actually being connected and using that, unless, of course, you can exclude out of it. And also being able to report at least one numerator in all of the measures. So basically what we're saying is your participation means you got to demonstrate, just like you did in meaningful use, that yep, we're able to do all of these things, or be able to exempt out of the rule. Now the performance score, this is new. And the performance score is basically going to look at different pieces that CMS is trying to get you to be conversant in, and that would be the patient portal or their electronic access to their records. The patient engagement, which is again patient portal, but now it brings into it survey information and being able to use direct to coordinate care with other providers, and also being able to exchange information with HIEs. Now that could be in the form of submitting CQM reports, or it might be in the form of an actual bona fide interface with the HIE. And by the way, anybody interested, you can connect today to Paleo. That interface exists, and that would be one way to hit a lot of the requirements. Additionally, you can sign up for registries and different reporting options, and those can be twofold. One, it might be something you need to do anyway to get the information that was once required of you in PQRS. You may need to be doing that, so lo and behold, it would count as a positive for you in the performance. So kind of to review, meaningful use, this is the last year to attest. A lot has changed, but the fact is you still have to deal with all of the measures, all of the measure groups. You still have to pay attention to it. So everything you're doing on your dashboard and running reports, you still got to keep doing it in the future. Anything you want to add, Bradley, to the change that's coming down the pike?
Yeah, I've been reading in a couple of instances where you know, part of the intent of this meaningful use was to actually get doctors to coalesce into bigger groups, and they found that it's not, bigger groups don't necessarily adopt or to these changes well or implement them well, and that smaller groups do. And so I'm interested to see that in designing the program moving forward, because a lot of this is put in on a sort of an experimental basis to see how well it works, and then make the adjustments necessary to get a successful outcome in the end. And I think they're going to start to take into account the smaller office and go, okay, how, you know, they've actually adopted some of these rules and regulations better than our bigger groups have, and can actually innovate as well. And so it's going to be it's an interesting time. It's going to be interesting.
Yep, I think it is going to be interesting, and I'm hopeful. You know, we saw a few years ago the realization that CMS was pricing primary care out of existence, and they came to the rescue with an increase in the E&M code reimbursement, which, you know, it also helped the specialists as well. Now I think they're going to see that, hey, we cannot run the solo and small office practitioners out of business, because if we lose those guys, we're going to be losing our ability to innovate. And so I believe what we're going to start to see is some relief for smaller offices, some ability to use your specialty organization to help you out and things like that. So if you are feeling like you have no choice but to join a bigger group or to join the hospital, there is hope. I'm not saying that isn't your best option, but I do believe that CMS is waking up to the fact that they need to keep you independent in order to keep the medical community healthy. Alrighty, and so this last chart here, it's only up here to illustrate one thing, and that is that meaningful use is not going away. In fact, it's going to get more complicated. We were originally hoping that stage 3 would hit by 2017. No chance of that happening. But you can plan on, by the end of 2017, it being defined and refined to the point where if you felt crazy enough to be able to take it on, you could take on the stage 3 requirements. However, looking at 2018 and 29, it would take an act of Congress to prevent stage 3 becoming the law of the land. So look for the requirements that are placed on you for reporting. Yeah, an act of Congress. We've seen that before.
We've seen that before. That's right.
So, but the point is, since we're going to have to report on this stuff, it's best to get an understanding of it now, tailor it to how it can have the least negative impact on your practice, or hopefully even, some positive impact. I know we've talked to a few offices that they really didn't intend on collecting certain pieces of information, and lo and behold, they were required to in order to do the PQRS reporting, and all of a sudden they're going, you know what, this is great, because this actually opened the door to a couple of additional things that we'd like to do with our patients: new revenue streams, better care, new relationship with some physicians they refer to. So it had a good positive impact. But just keep in mind, meaningful use is not going away. Only the one-time attestation that you do at the end of the year is going away. It's going to be replaced with MACRA, which is designed around your EMR in real time, providing data to the different entities that are going to help you measure. And for those data items that don't lend themselves to real time, we're going to have the registries and CQM reports and syndromic surveillance and things like that, where you populate patient lists in order to communicate. But it's going towards more data and more information, and going away from living in a silo and not having to worry about what's going on around you.
Which is another reason that they're trying not to drive the smaller practice out of the arena altogether, because getting the data, making decisions, and actually implementing a workflow within the clinic to get them real-time data that they can actually measure is not something big groups do successfully. It takes them too much time to do it. And so built into the, so while they pay for performance, hopefully I made sense there. Well, so while they're paying for performance, they're going to need that smaller practice, and so by adopting the spirit of what they're trying to accomplish here, which is getting that data in as they pay based on or penalize based on a budget neutral program, which means they don't want to they can't save money and not plow it back into the program. So that's why they're going to give, for example, performance payments to those who do better, who manage the patient their patient health care populations better, and you'll get more money, right? But then if you're getting more money, somebody else is getting less, and so that's why they need these smaller groups and innovate. They really do want to reward those people who do embrace the program.
Yep, totally agree. So when we put this presentation together, we spent a ton of time on the CMS website. The 3 links that I have included here are just the starting page for the 3 different components we spoke about: PQRS, meaningful use, and MACRA. You can drill into those. There are tons and tons of learning modules, videos you can watch. The MLN News articles are in referenced here, files, Excel and PDF files. Everything that we put together came basically from CMS. We will be sending out this PowerPoint presentation in PDF form, along with PDFs of the measure group manual, the qualified registry list, and that list of the cross-cutting measures. We'll send all of those out to everybody on this call. We're also going to have those available on our website. So we hope that you'll all take advantage of that. So are there any questions, anything that we can cover for you before we end the webinar? And I don't see any additional items in the chat. Let me make sure nobody's muted that wants to be speaking. No? All right. So Susan, you're the only one that I see muted. Any Susan Taylor, any questions?
No, I have
all right. All right. Well, thank you everybody for joining. I hope this was helpful to you. I know that I learned a ton when we were putting this together. So we thank you, and we look forward to seeing you again on a future Phasis Group free webinar. Have a good afternoon, everybody.
Thank you, everyone.
Thank you.
Thanks.
Thank you.